you kind of have to be a detective to figure it out.
You have to be a detective. I mean, in all of medicine, you have to be a detective. The neat thing, though, in pain management is sometimes the clues are extremely vague. Sometimes the biggest clue that we have, or the biggest asset that we could have from a pain management side, would be something called a functional MRI of the brain, which is something that is available in just a few places, throughout any given major city. I think in the city of Chicago, there's only a handful of functional MRI machines. A lot of them are at universities. None of them are covered by insurance. It's one way of looking into the brain to see how neuronal activity is occurring. So the bottom line is, there's, at any given time in my office or even at any hospital, there's no lab test, there's no picture that's going to give me the answer. It really is detective work where you have to also use your intuition and experience to really come to a conclusion of what could be going on with that patient.
So if you get this functional MRI, does it show you a particular part of the brain that relates to a certain part of the body where the pain is?
Yeah, so what's been really helpful and really interesting in the last few years, there have been a lot of studies that have come out for functional MRIs in multiple different disease processes. Some of those disease processes are things like ADHD or PTSD. ADHD, hyperactivity, and PTSD, post-traumatic stress disorder. CRPS, which is something that we've studied, is chronic regional pain syndrome. Fibromyalgia as well, which is chronic widespread neuropathic or nerve pain that occurs in all four quadrants of the body, but is hallmarked by central sensitization. That means it's hallmarked by impaired pain perception. The way the body perceives pain, the way the brain actually perceives pain is hyper amplified. It's like if you had your radio and it was on the one position, the volume was on 1. Well, in some of these patients, the volume's on 10. So even if you're whispering, it seems like you're yelling. And so what the functional MRIs do is they almost provide a fingerprint type of sort of picture, in the sense that different disease processes have different parts of the brain that are either hyper or hypoactive. And with things like functional MRIs, which is a little different than PET scans, but PET scans can also provide you some of this kind of information where you actually see activity in the brain that's either hyper or hypoactive. And if you do those studies, you'll see that different disease processes present themselves in similar patterns. Similar parts of the brain. One part of the brain that tends to be active in some of these disease processes is the insular cortex. So when we start seeing the insular cortex lighting up, we see that definitely with fibromyalgia. We also see that with CRPS and PTSD as well. But it's something that is not widely available, and it's definitely not available in sort of the private practice setting. I'm hoping eventually, maybe 5 years from now, or who knows, 10 years from now, eventually, hopefully, that will be something that might be actually widely available and covered by insurance companies, which would be nice. It would just add to our arsenal and make things a lot more straightforward. What it would do is it would allow non-pain physicians to have some type of objective tool to verify that the pain patient actually is, has pain or has pain that's consistent with a certain disease process.
So, my interest is in interstitial cystitis. So, from your experience, does this functional MRI show up a particular place that's hypo or hyper pain sensitive in that MRI for the IC patient?
As far as I know, I haven't seen any data that specifically describes interstitial cystitis as having functional MRI changes that's specific for interstitial cystitis. And I'll tell you why. It's because with interstitial cystitis, we're thinking that there's an organic issue that's going on in terms of the bladder wall being painful. Now, what you will probably see on a functional MRI with someone who has interstitial cystitis for a long period of time is you'll see similar changes that you will see with other patients who have chronic pain for a long period of time.
Okay.
So, and they've done those studies too, where they've looked at chronic pain patients, for whatever reason, maybe that's chronic lower back pain or chronic nerve pain or chronic, diabetic neuropathy or something like that, where their nerves are hurting in their feet and things like that. And they've done functional MRI studies in those chronic pain patients where they found that there were very specific changes in the brain that was consistent with chronic pain. And I'd imagine that with an IC patient or an interstitial cystitis patient, you would end up seeing those kind of functional MRI changes, but not the fingerprinting that would isolate out that this is IC. What you usually see with the fingerprinting is if there's a central problem, if the condition actually originates from the brain. And it's not to say that it's all in your head or anything like that. It's to say that the brain is an amazing organ. It can, just as much as the brain can suppress pain signals, it can hyper-amplify pain signals. And that's what we see in certain disease processes like fibromyalgia or, again, PTSD or CRPS. You see this hyper-amplification of pain signals, and it's all because the brain itself is telling, the brain's telling the brain that there's more pain than what they should be feeling.
Okay. So how did you become interested in working with the Interstitial Cystitis Association? Because we're very glad you did, but how did you get connected with them?
It actually goes back to my fellowship. The fellowship training that I had after residency was an interventional pain fellowship, and in that fellowship, it was somewhat rare in the sense that we actually had a relatively comprehensive interventional exposure as well as a comprehensive non-interventional exposure, and so we were exposed to pelvic pain and how to treat pelvic pain. I would say with some degree of thoroughness, and that's unfortunately it's something that is not widely taught. So pelvic pain is not something that's widely taught in a lot of interventional pain programs. Pelvic pain is something that's not really, widely addressed even in the OBGYN community or the primary care community. It's one of those things that's vague. A lot of people don't know exactly what to do with it. It can be very frustrating to treat. So that's why you'll end up seeing a lot of patients, even IC patients. I think the data is that they'll see many physicians over the course of many years before they're actually diagnosed with interstitial cystitis, and part of that is just because the knowledge base that's in the medical community, or I guess the patience that some physicians have with this complex disease is one that they're just saying, you know what, I don't know how to treat it, and they leave it at that. So in our fellowship, we did actually specifically address that.